right, welcome everyone. My name is McKenna Kresley, and I am the Communications and Marketing Manager at IDF, and I will be your moderator for this education event. Today, Dr. Jeffrey Bednarski will be presenting on the topic of blood disorders and primary immunodeficiency. There will be time for questions at the end of Dr. Bednarski's presentation. Please submit any questions you have to the presenter in the Q&A section of the platform. Dr. Bednarski is a member of the Pediatric Immunology and Stem Cell Transplant teams at Washington University in St. Louis. Dr. Bednarski has both clinical and laboratory research projects that are centered on development of immune cells and treatment approaches for immune deficiencies. His laboratory research investigates the signals that are necessary for normal stem cell and immune cell development. His work is interested in understanding how errors in these developmental programs lead to leukemias and immune deficiencies. Welcome, Dr. Bednarski. You can take it away.
Thank you. Thank you very much for that very nice introduction. It's my pleasure to be here today. I guess I don't need to introduce myself because McKenna did a great job of that already. So I'll jump in and talk to you about the immune system and blood disorders that commonly occur or commonly co-occur in patients with immune deficiencies. And so I guess a little bit of way of introduction on it. While I'm a hematology oncology trained physician, my interest really is in the immune system and its interaction with our blood cells. And so this has been an ongoing interest and passion of mine for many years. All right, so I do have a few disclosures. None of these are relevant to this current talk. But they're listed there. Okay, so a brief introduction to the immune system, which you guys are all very familiar with. But the immune system in its simplest terms really has two jobs. And the first one is the one we're all familiar with, right? That's get rid of invaders. So kill bugs and kill cancer, right? Like that's its job. Like make sure we don't get infections, and if we do, clear it. But its other key part is to be able to distinguish healthy cells and leave those alone. So just very simple schematic here, an immune cell here labeled as a T cell. If it binds to something that's not you and not me, it should kill it. So that's a non-self cell, like a bacteria or a virus. But if that same T cell sees one of our own cells, like a liver cell or a blood cell, it should leave it alone and not kill it. And so it works on this very simple principle of attack non-self and preserve self. The challenge in patients with immune deficiencies is that those immune system errors sometimes confuse that immune system's ability to distinguish between self and non-self. And consequently, the immune system can start attacking own cells of your body. And so you hear about autoimmune disease in patients with immune deficiency. That's one of those manifestations of that immune system attacking other organs like skin and joints. But it can also attack blood cells and destroy them instead of leaving them alone. So that's called a break of self-tolerance, but basically results in destruction of your own cells. So what are the components of blood that we'll be talking about today? The first one is white blood cells. These are the cells in your blood here that fight infection. So if you lose these, you have increased infections. Other components of blood are your red blood cells. This is what carries oxygen around through your body, where hemoglobin is. And so the loss of this results in anemia and decreased delivery of oxygen to your tissues. And then the last component is platelets. These are these little, what look like little specks or fragments in here. Their job is to stop bleeding. And so if you lose them, you get bruising or bleeding. How do immune cells attack blood cells? Okay, so I've broken this down into two components of the immune system. There's B cells and there's T cells. What I've shown you in the picture so far are T cells. These cells normally directly interact with the target cell. So they bind to that cell or kind of form a union with that cell, and then they kill it. In immune deficiencies, T cells can attack and kill normal tissues, including blood cells. The other component of the immune system is B cells. These cells produce antibodies. These are those circulating molecules in your blood that help you fight off infection. So when you get a vaccination, we measure antibodies in your blood to prove that you responded appropriately to that vaccination. But these are also replaced by, IVIG and Hizentra, which many patients with immune deficiencies end up on. So B cells should normally produce these to fight infection, but in the case of some immune deficiencies, they can actually have an error and actually make antibodies that attack blood cells. So either one of these cells, if there's an error in them, you can attack blood cells. So what are some of the blood disorders that we see in patients with primary immune deficiencies? First one is sort of autoimmunity. This is based off of cells like T cells and B cells. So T cells and antibody producing cells attacking those red blood cells or other blood cells. This is most common in patients with common immune deficiency, Wiskott-Aldrich, common variable immune deficiency, ALPS, those kind of disease categories. You can also have immune dysregulation, where the immune cells can turn on, but they can't be turned off. And in that case, when they're overactive and stay active for a long time, then they can start attacking your own cells as well. This is more common in diseases like IPEX, can also happen in ALPS or XLP. So different immune deficiencies, different problems with the immune system, but can still attack the blood. These two up here result in sort of direct attacking on those red blood cells, or excuse me, any of those blood cells. You can also have associated bone marrow failure with some immune deficiencies. So your bone marrow is what makes all the cells in your blood. And in some immune deficiencies, you lose function of that bone marrow. And so then you're not producing cells in the blood. So that's not technically a destruction of the cells, but it can be a consequence of the immune deficiency as well. And then finally, you can have indirect factors in immune deficiencies that lead to low blood counts. So patients with immune deficiencies are more susceptible to infections, and those infections can suppress bone marrow function as well. So there's many different aspects of immune deficiency or parts of that that could lead to low blood cell counts. Changes in blood counts are more common in some immune deficiencies than others. And we're starting to understand this better. It's really related to how the abnormalities in the immune system result in different regulatory changes in the cells. And so patients with autoimmune lymphoproliferative syndrome, or ALPS, up to 50% of them can have low blood counts, like anemia or low platelets or low neutrophils. It's also quite common, actually, in common variable immune deficiency, and 5 to 20% of patients can develop those cytopenias. And it's actually about 20% of those patients that are diagnosed with CVID because they've shown up with cytopenias. Cytopenias is the medical term for low counts in your blood. It can be, low white blood cells, low hemoglobin, or low platelets. Overall, the occurrence of those cytopenias is about 100-fold to 1,000-fold higher in CVID than in the general population. All right, so if your immune system is suppressing or lowering those blood cells, how would you present? Like what symptoms would you have, or what clinical findings would we see? And frequently, we don't see anything, except when you get your routine lab work, we notice that there are low counts in your blood. But you can have some symptoms, like with low platelets, you can have bruising and bleeding. With low red blood cells, you would have symptoms of being anemic, so fatigue, pale appearance, decreased energy. And low neutrophils, you would have increased infections. So we'll walk through each of these in a little bit more detail here. So immune-mediated thrombocytopenia is what we call low platelets that are caused by dysregulated immune system. And in this case, it's almost 100% of the time due to antibodies from that abnormal immune system causing destruction of platelets. This is the most common low blood cell count or cytopenia in immune deficiencies. And so just schematically here, that's that immune cell, the B cell, producing these antibodies, and then these antibodies combine to platelets and chew them up and destroy them. And so then they don't work. Platelets have two primary functions. One is to plug the hole in blood vessels. So when you get an injury to a tissue, you make little tiny holes in those blood vessels when that happens. That's why you get bruising, is from little holes in blood vessels. So the platelets come in and plug it so bleeding doesn't continue to happen there. And they also serve as a platform for generating a clot that then repairs that blood vessel. So when you don't have platelets, you can't plug this hole, or you can't fully repair that hole. And as a result, you end up with increased risk of bleeding. The most common thing that we see in low platelets is this kind of unique rash, which has these pinpoint red spots all over the place. You can see it on the skin, very commonly on shins, or on the face if you're coughing. But you can also see it on the back of the palate here, that can show up. And these are due to these little tiny blood vessels sort of getting punctured or leaking a little bit in the skin. You can get bleeding, like true overt bleeding, and that's most commonly in the mucosa area, so the mouth and nose. So they're more fragile and you get more bleeding. Can happen with brushing your teeth or just more frequent nosebleeds. Immune-mediated anemia. This is when you have destruction of your red blood cells, which are what carry oxygen around in your blood. So you result in a low hemoglobin, decreased ability to get oxygen to tissues. And the symptoms are usually pale appearance. So red blood cells are what sort of keep our skin looking healthier. You can be fatigued, lightheadedness, and shortness of breath. Immune-mediated neutropenia, so this is low white blood cell counts, typically results in infections. So neutrophils are key components of the immune system and defense against infections. This is a diagram showing how neutrophils can be rolling around in the blood vessel, and then when there's an infection here, they leave the blood vessel to go fight it and get rid of it. So if you don't have neutrophils here, they can't get here to fight off that infection. They're one of the first responders to infection. They're absolutely critical to early control of infection, particularly some types of bacteria and fungus infections. So when you lose them, you have increased risk of infection and possibly more severe infections. So how do these low blood cell counts happen when your immune system is not working correctly? And so this is a sort of diagram of how that works using platelets as an example here. Platelets being these yellow ovals here. So in the first case, you get B cells. Those are the ones that produce antibodies, and they produce antibodies against those platelets. Once those antibodies bind to those platelets, they're then soaked up by the spleen, which is sort of the garbage disposal of the immune system. Just chews up everything that our immune system labels as being foreign. So these are labeled as foreign. They get chewed up by the spleen and then destroyed. You can also have T cells that are helping those antibodies produce antibodies, but the T cells themselves can also bind to platelets and destroy the platelets directly, or it can sometimes affect the cells that are responsible for making platelets. That's called megakaryocytes. In response to this, the body tries to make more and more platelets, so often increases megakaryocytes so that you have more of them in the bone marrow to make more platelets, but every one time a platelet is made, it gets destroyed by these antibodies or by these T cells. This is important to understand because this is how we determine how to treat these cytopenias in patients. And so the treatment is really targeted at these specific parts of the immune system. The most common treatment that we use in this case is steroids. Steroids inhibit those T cells, so they can't destroy the platelets, but can't provide help to make antibodies. But more importantly, what steroids do is they stop the spleen from really breaking down these labeled platelets that are labeled for destruction. So steroids work well sort of at a couple different stages here. Another treatment that we use is to just eliminate your B cells, right? So if B cells are the problem and they're making these abnormal antibodies here, then let's just suppress those B cells. This is rituximab that we use here. Rituximab binds to this protein, CD20, on the surface of that B cell and basically shuts down that B cell. So if there's no B cells there, you can't make any more of those antibodies to be destroyed, to destroy those platelets. Steroids work very quickly because they inhibit right here. Rituximab works a bit more slowly because even once you get rid of the B cell, these antibodies are still circulating around your body for a while. And so until they disappear and aren't made anymore, you're still going to have low platelets. So rituximab takes about a month to really work, whereas steroids take a couple of days. We can also use IVIG, which many patients with immune deficiency are getting anyways to replace normal antibodies to fight infection. But if we give IVIG at a really high dose, it actually has some immune suppressive properties where it can block these B cells from producing antibodies or block the spleen from destroying antibody-labeled platelets. The last thing that we can do, which we try to avoid doing, particularly in patients with immune deficiency, is we could take out the spleen. If you remove this sort of garbage disposal here, then there's nothing to destroy these platelets. Even though they're labeled for destruction, they won't get destroyed. And so then they can continue to circulate and function. We really reserve this for patients who have cytopenias that are refractory or not responsive to any other therapies, because the spleen plays an important role in normal protection against infection. So while it would be helpful here, we can also increase risk of infection by taking it out. The other strategies would include other ways of using immune suppression. So these are other medications just to sort of quiet or turn down the immune response. And that's by basically suppressing T cells here. So we suppress them from providing help to those B cells to make antibodies, but also preventing the T cells from destroying those platelets. So it's another option. This option has really become more and more used as we have a better understanding of what the individual differences in every immune system is, and if we can target that specifically with a specific medicine. Finally, the last thing we can try is to stimulate more platelet production. So if they're getting destroyed, make more, right? So tip the scales. If you make more, if you produce faster than you're destroying, you'll have more platelets circulating. All right, an important disclaimer here is that not all cytopenias, so not all low blood cell counts in immune deficiency are due to immune-mediated destruction. Sometimes there's normal production of blood cells can be suppressed by the inflammation or chronic illness that occurs in some immune deficiencies. And so it's our job as the medical team to make sure we're distinguishing between whether it's this suppression of production or whether it's destruction of cells. So what are some of these more severe blood disorders that can happen in immune deficiency? As I mentioned, the immune system role is to distinguish self from non-self. One of those non-self things is cancer. Even though it arises from your own cells, your immune system actually does a really good job of screening to delete or eliminate any cancer cells. And so defects in your immune system, depending on the defect, can also put you at an increased risk of malignancies. One in particular that occurs in patients with primary immune deficiency is a lymphoma. This is a proliferation or an expansion of malignant immune cells actually in the lymph nodes. And so you get these hot spots here. So these black spots here are spots that we have higher metabolism or higher rate of glucose consumption, energy consumption. And those are the big lymph nodes that we can see. This is uncommon, as I mentioned, but it is a known risk in some immune deficiencies. And it's really a failure of T cell function. So these T cells should be binding to tumor cells and directly killing them. But if you have defects in T cell function, you lose this immune surveillance for cancer cells, and thus an increased risk that they can grow and become a lymphoma. Treatment for these requires chemotherapy, which treats the lymphoma or the cancer, but it doesn't treat the immune deficiency. So there's still a risk of recurrence of that cancer in immune deficiency patients. And so in that case, there should be discussion of a bone marrow transplant to establish a new immune system. And in this case, that works by basically replacing the dysfunctional immune system with a new one that will have this appropriate surveillance for blood deficiencies. All right, so what you should know about blood disorders and primary immune deficiency is that good routine follow-up to monitor blood counts and a physical exam is important to monitor for signs of low counts. So basically, at every follow-up, your physician and medical team should be monitoring your blood counts to make sure they're in the right range. And if there are any abnormalities, then checking to see what the causes of those are. If you notice any symptoms of low blood counts, you should let your physician know. These symptoms, as I mentioned, would be increased risk of bleeding. So like nosebleeds or gum bleeds when you're brushing your teeth, or these that pinpoint red dots on your skin. And the increased risk of infections that comes with immune deficiency anyways. But if you're noticing a change there, then we would be looking at those neutrophils as well. Most importantly, a lot of these need to be managed in consultation with a hematologist, so in consultation with a blood doctor. As we talked about, there are several good treatment options out there that are available. And so we have different ways of managing these to really help improve them, even in the context of a dysfunctional immune system. All right, that's what I got. So I'm happy to answer any questions.
All right. Thank you so much, Dr. Bednarski, for sharing that wonderful information on something I think a lot of people with primary immunodeficiencies can relate to. We now have some time available for Q&A, but before we begin, please remember that everyone's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with questions concerning a medical condition. All right, and with that, we do have some great questions. So first, I'm going to start with this first one. They said, could you explain the connection between PI and lymphoma? I have CVID and NH follicular B-cell lymphoma, both diagnosed concurrently. No chemo, but weekly Hizentra. What might trigger the cancer to become more aggressive? Is this event linked to things going on in my immune system, such as infections or autoimmune diseases?
That's a great question. So it's about, I'm going to say about 30% of patients, if I remember correctly from the data on it, 30% of patients with CVID that can develop a lymphoma. It's, as best as we understand it, it's really a defect in these this immune surveillance. So your immune system on a regular basis is making sure that any cells that are potentially cancerous are eliminated and killed. So when you have a weakened immune system, like in CVID or in other immune deficiencies, you lose that surveillance mechanism, and then cancers can occur. Maybe not surprisingly, maybe is, but the most common cancers that we see are B-cell lymphomas. And I think that part of that really comes from the fact that our B cells are constantly trying to respond to infections. And so they undergo a lot of different changes in the cell and expansions and proliferations. And so T cells help keep that in check. So I think that answers a little bit about the mechanism of it. And then I forget what the next part of it was, about treating it. Oh, no, what would lead it to get more aggressive?
Yes.
That was the other question. We have no idea. I think as long as there's two components to it. The first is the cancer itself can change. Once it's developed, it can change and become more aggressive. The second component to it is the immune system. And can the immune system, even though it's weakened, and you have this development of some lymphoma there, can it still keep it in check to some extent? So in many cases, in patients with CVID, we try to boost that immune response or suppress the abnormal aspects of the immune response to try to treat these early malignancies without necessarily having to go to chemotherapy first. Sometimes we don't have a choice and we have to go to chemotherapy. So I've had a couple of patients that have presented exactly like the case described.
Thank you. We do have another question. This person asks, I've been on IVIG Gamma Guard for CVID for 5 years. 2 years ago, I was diagnosed with iron deficient anemia. IV iron has not helped. Is iron deficient anemia different than anemia found with CVID? Is the treatment any different?
That also a really good question. So iron deficiency anemia in and of itself can be just a general diagnosis. So there are millions of people every year who have iron deficiency anemia, from blood loss, from poor iron intake in the diet. And in those cases, if you just give iron back, you fix that anemia and you replace those iron stores. So in that case, it's just a matter of their iron stores should have been this high and they were down here. So you repleted it and you fixed the problem. In patients with immune deficiency, you could have iron deficiencies simply from that standard cause, like low iron levels. And in that case, it should be very responsive to iron replacement. But there's another component to getting iron from your blood into your red blood cells to make hemoglobin. And that's related to the liver functioning correctly. And so inflammation suppresses your body's ability to actually use iron correctly. And so even though you're getting iron appropriately, it can't actually use it in an appropriate manner. And that's really called inflammation-associated anemia. And it can present just like iron deficiency anemia, but it won't be responsive to iron replacement. And the best way to treat that is to really suppress the inflammation or the abnormal immune response that's preventing the iron from being used.
Okay, great. We have a lot of questions coming in, so I'll just keep going.
Okay.
Next one is, I've dealt with immune-mediated thrombocytopenia and find that sometimes, even when my platelet counts are in normal range, I still experience easy bruising, purpura, and bleeding gums. Is this a typical immune-mediated response you see in patients?
Also a great question. So with there's some subtleties or some differences to ITP. So when you have immune-mediated destruction of platelets and your platelet counts are really low, you have these bleeding problems, but they're not as severe as if you lost platelets by another method, and that's because your bone marrow is kicking in and making new platelets. So the platelets that are circulating are really young or freshly made platelets, which do a better job of stopping bleeding. So when you've treated it and the platelet counts come back up, in most cases, the bleeding should stop. But in sometimes there's some underlying injury to those blood vessels or those mucosal barriers that even with normal platelets, you can still have some spotting, bleeding, and stuff like that. It shouldn't be as severe as when your platelets are low, but it can still happen sometimes, even though your platelets have recovered to normal.
Okay. If someone has had low WBC for over 30 years with normal differential and now has climbing IgE, the WBC is thought to be familial. What PID conditions do you see with this combo?
With a low WBC and a high IgE.
Yes.
There's several that it could be. And so there's a lot of different testing that needs to be done. You know, some I can even see it with severe combined immune deficiency. So some of the mutations in that case, if you have a leaky mutation, so you make some cells, but not enough, you have low counts, but the cells that are made aren't working correctly. And part of them not working correctly is that they make a lot of IgE. And so you get these rashes and stuff with it. And so there are basically any mutation that sort of prevents, it causes a slight weakness, but not a complete loss of immune function, can result in sort of that combination.
All right, great, thank you. Is there a connection between CVID and constant light menstrual bleeding?
Not that I'm aware of specifically, but I would totally have an evaluation by a hematologist to make sure that there's not an abnormality in platelets, or there are other components of the clotting system in addition to platelets that I didn't talk about today, but you can have immune responses, those that prevent function as well. And so if it's been going on for a while in that context of CVID, it's worth getting an evaluation to make sure there's no abnormalities there.
Perfect. I have CVID and other comorbid conditions. My iron level is fine, as are my B levels. I do take a minimal amount of fish oil. I bruise all over my legs for no reason, just like my mom used to, although I normally don't bleed. Should I be concerned?
Nothing that I can say of specifically to be concerned about. Lots of patients have easy bruising that's unrelated to their immune status or immune function. If you find yourself in that situation, you should get evaluated, as you've done, by a hematologist and make sure there's no abnormalities in platelets and clotting. And if not, then there's nothing to worry about usually in that case.
Great. Next question. Could you discuss what ALPS is?
ALPS is autoimmune lymphoproliferative syndrome. So this syndrome there's several different causes of it, but the end result is that your immune system cannot turn off. So when you get an infection, or immune system tries to respond to an infection, what it does is causes huge burst in activity, which includes proliferation of the immune cells. And that's important because you want a huge army of immune cells to attack that infection and kill it. After it's killed that infection, that army of immune cells should contract. So it gets smaller and smaller and returns to normal. In ALPS, that contraction doesn't happen. So those cells just keep expanding. And you get basically this proliferative expansion of cells. The consequence is that you have a whole bunch of cells there that aren't actually really fighting an infection. And so they tend to then fight against your own body. So you get autoimmune diseases associated with it.
Okay, great. Questions keep coming in, so we're just going to keep chugging along.
All right.
Next one. I had anemia from age 14 to 36 when I was finally diagnosed with CTLA-4. I'm gonna butcher this.
Haploinsufficient.
Yes.
Yeah.
I had 99 blood transfusions in this time. Is there hope for the future that docs can recognize immune-mediated cytopenias and diagnose PIDs more quickly?
Yeah. Yes, there is hope. So it has become an increasing recognition amongst hematologists that anyone who presents with a cytopenia, particularly what looks like an immune cytopenia, should undergo an immune evaluation at that time. So, and then depending on what that immune evaluation shows and what the course of that cytopenia is, then should be sent for genetic sequencing to look for exactly these kind of things. So this has been, it's a huge education campaign within IDF, as well as many of the other immune deficiency advocacy groups, to really raise awareness about this so this testing gets done. And we've found with recent publications that up to 20% of patients with just low platelets, so immune-mediated destruction of platelets, actually have an underlying immune deficiency, depending on age, 20% of adults. And 50% or more of patients who have immune-mediated destruction of platelets and red blood cells. So if you have both, then you have an even higher chance of having an underlying immune deficiency. So yeah, we're getting better. But even as recent as 15 years ago, it wasn't standard to screen these patients for immune deficiency, but it's now standard.
Great. Next question. Are all hematologists familiar with treating anemia in a patient with CVID, or are there hematologists who specialize in primary immunodeficiencies?
All hematologists should be aware of the general principles of treating anemia in patients with primary immune deficiency. That the mechanisms that lead to that anemia, either immune-based or iron-based, or this inflammatory anemia process, we see in other conditions as well, so we know how to treat them. There are becoming more and more hematologists, particularly in pediatrics, but I think it's also starting to happen in adults now, that are specialized in this area. And so there are clinics that are popping up that are basically immune hematology clinics or immune cytopenia clinics. And those are hematologists that specialize in treating these conditions.
All right. Next question is, what can elevated NK cells mean? Is there any association with CVID?
I don't know about an association with CVID. Generally, elevated NK cells are, again, depends on levels, are usually elevated because they're trying to fight off something, and NK cells work really hard to fight off infection, but also can fight off malignancy. And so usually you see them, it's a transient process that goes up and comes down when they're trying to fight something. If it's a persistent elevation, it can be an abnormality in those NK cells being able to turn off after responding. So similar to an ALPS-like condition. And so there's further testing that needs to be done to look at that. CVID usually affects B cells and T cells, so it doesn't affect NK cells. But the inflammation that's there in that setting could result in higher NK cells.
Great. Next question. I am on anticoagulant for AFib. How do we know if and when my CVID might cause thrombocytopenia?
So we don't know if and when it would cause it. It happens, immune thrombocytopenia happens in, I think, 50% of CVID patients. Oh, we said 20, I said 20% before, so sorry, 20% of CVID patients. But we don't have any way of predicting ahead of time who's more likely to that happen in than others. So the most important thing you can do is just to have routine blood checks.
Great. Next question. Are there best methods and or IV products that work best for iron deficient anemia in people with CVID?
If it's, so as we talked a little bit about before at the previous question, if it's sort of true and unrelated, so you have CVID and you have iron deficiency, then any of the iron products available should help you replace those iron stores. But there are, in many cases in CVID, where that it's a pseudo iron deficiency, meaning it's not just because of low iron stores, it's that your body can't use that iron correctly. And in that case, the most important thing is to try to turn down the inflammation in CVID. And so it's a combination of having your immunologist and your hematologist working together to find the right answer.
Next question. My hematologist just added LGL autoimmune to my list of issues. What is LGL autoimmune? I do have CVID and neutropenia.
So, yeah, LGL. It's a expansion of large lymphocytes, which are thought to be more of these activated lymphocytes. And so I don't know exactly what the LGL autoimmune part is in it, but in general, it's just because they're seeing an expansion of these larger immune cells.
Okay, thank you. We have one question left, as long as someone else doesn't submit one while you're answering. But the potential last question. I'm on Hizentra for hypogamma. WBC stays 3. Have had 4 PICC lines in 3 years. When I'm acutely sick, I have no fever, present with high BP, and WBC count doesn't elevate. Currently waiting on genetic tests and probably BMBX next month by hematologists and oncologists. Any thoughts?
Ooh, sounds like you have a great team of people helping you out there. I don't know. It is unusual not to have your immune cell population go up in response to infection. There are some immune deficiencies that result in an inability of your immune cells to leave the bone marrow or to leave their places of storage to go fight an infection. And so in that case, they work fine if they could actually get there. They just can't actually traffic to the right site. And so one of the places where they stay and get stuck is in the bone marrow. And that's the reason for the bone marrow biopsy, to see if basically what you see is normal numbers of immune cells there, but they're not able to leave and go to the rest of the body. So that would be one of the things I would be looking at. And then the other part would be, looking at what immune cells are in your blood, how much of it is neutrophils versus B cells versus T cells. And that might give you them a clue as to sort of what the underlying cause of that is.
Great, thank you. That was the last question. So with that, our time together has come to an end. So I want to thank you so very much to Dr. Bednarski. It has been an honor to have you join us today. If anyone on this session decides that they have a question later on that they wish they would have asked, we do recommend you to go to Ask IDF on primaryimmune.org, and you can submit your question there, and our staff can either reach out to Dr. Bednarski or another trained professional to get your question answered. So I hope you all enjoy the rest of the conference, and hopefully we will all see you soon. Thank you for joining.